Hey everybody, we're just gonna give a little time for people to join in. We'll start at 6:05 sharp. All right, we'll go and get started. Hey everybody, thank you so much. We really appreciate you guys as always. Welcome back. We're really excited. This is going to be an awesome session. Kind of a unique specialty that we're really excited to hear. And from the little time that we've spent with her, she seems really, really cool. So just really briefly, we'll go over the quiz just in case you have any questions.
So same thing, 5 multiple choice questions. We'll be giving out the link at the end of the session. It'll be in the chat box that you should see either at the bottom or to the right of your video. As long as you get 4 out of 5 correct, you'll get the certificate emailed to you within about a week. We usually do it within 2-3 days though.
Yeah, so stay on the lookout for that as soon as the session's over. Aside from that, guys, just please feel free to be as active in the chat as you like. We're going to be relaying all your comments and questions back to Kaci the whole way through. So if you have any question, whether it's a general question about the case study or anything in the presentation, just feel free to ask anytime and we'll get back to her about it. But okay, guys, I think that is everything. Kaci, if you're ready on that side, it's all you.
Okay. Just a heads up, I can't see anything but my screen. Is that right?
Well, we can see your presentation right here. So
okay, perfect. I couldn't see myself, so I wasn't sure if anyone else could see me.
Oh yeah, so so your presentation is up, and then you're in like a tiny little window in the top of the screen.
Oh, okay. All right, well then we'll just go ahead and get started.
Right,
so my name is Kaci Hartsock, and I am a certified physician assistant, and I work in cardiothoracic surgery. So just a heads up, this is my first time doing a virtual shadowing session. Several individuals have reached out on Instagram, but I wasn't really sure what all it entailed. So I'm really excited about this and hopeful that I could potentially continue doing this with some of you. Okay, so let's go ahead and get started. Oh, I'm sorry, I'm really bad at the computer. Oh, here we go. So no financial disclosures, all opinions are my own and in no way represent my employer or any of my affiliated organizations. Okay, so a little background. I grew up in Pennsylvania and attended Virginia Tech for my bachelor's in undergrad. So my bachelor's of science in human nutrition, food, and exercise. While I was there, I was active in like personal training and group exercise, thinking that maybe I wanted to do something along those lines. So I was interested in medicine, but also enjoyed fitness, wasn't really sure. Shortly after graduation, I started working as a medical scribe in the emergency department. I did that for about 6 or 8 months and then took a chief scribe position in some outpatient facilities, working in primary care, and then some specialties like hem-onc, endocrine, women's health, OB-GYN, and I think that was the bulk of it. So after working as a scribe, I still really missed fitness and thought maybe I wanted to do something more along the lines of like clinical exercise physiology, which would be working with patients in like a cardiac rehab or a pulmonary rehab setting. So I went back and got my master's of kinesiology, and I focused on clinical physiology at James Madison University. And within probably the first semester, I realized that I wanted more medicine. So while I was pursuing this degree, I also decided that I'm going to go to PA school next. So then while I was at JMU, I worked as a community health program instructor for a diabetes prevention program, as well as a diabetes educator graduate student intern. So I worked inpatient, outpatient, and just helped patients better understand their condition and insulin and oral medications. So, and then at the bottom, you'll see that I have other, and I call this other because I'm not really sure how much it played a role in my healthcare experience for getting into PA school, but I threw it on my CASPA anyway. So personal training, because we certainly did like health assessments, and like we had to be familiar obviously with blood pressure and heart rates, and you know, if the patient's on a beta blocker, realize that this can drop their heart rate. What else did I put on there? Also, I was a graduate student intern or director for a nonprofit that emphasized or focused on women and children's health specifically in physical activity and nutrition. So again, things that I threw on there, it was a lot more like community work, but something that I thought would benefit my application. Okay, so that's kind of my background. That was my experience getting into PA school and my previous degrees. And I have since moved to Cleveland, Ohio, and that's where I'm practicing now. Just a kind of get to know you sort of thing. So I'm really interested in leadership, as well as advocacy and policy, any sort of like community outreach, public health, research. I want to do everything. And then when I'm not working, I really enjoy weightlifting, boxing, hiking, bouldering, anything that'll get my heart rate up. And then now that I'm working and I don't feel like I have to go home and study every day, I just love reading leisurely, preferably nonfiction. All right. So why CT surgery or cardiothoracic surgery? So I actually started PA school thinking that I was going to do primary care or even endocrine, as that's where the bulk of my experience came from. But after I finished my general surgery rotation, and I had a little taste of thoracic medicine doing that, and then spent some time in the ICU, I really liked both of these settings. And so someone had suggested a CT surgery rotation that we had at my program, said it was great, and I chose that as one of my electives. And it really is, at least in my opinion, so I'm a little biased, that it's the best combination of medicine and surgery. You have a lot of autonomy in the OR, which I'll get to next. But then you do still practice a lot of medicine once the patient gets to the ICU and they're on the floor, you know, just managing their hemodynamic status and now I'm jumping ahead, and their longer length of stay post-op. So before I get there, let's go back to the OR. In the OR, you basically have your own surgery that you're doing, especially when it comes to CABGs, mainly when it comes to CABGs or coronary artery bypass grafting. So as PAs, we are solely responsible for taking vein from the leg or the radial artery from your arm. And I will get into more detail about this later. And then I just felt like there was a really strong team bond. And granted, it goes without saying that that should be the case in all specialties or all areas of medicine. But in my experience, I just felt a little more in CT surgery. I just felt like everybody was, one step ahead. The surgical, the scrub nurse or the surgical tech, like always knew what was coming, was on the ball. Same thing with the PA and the surgeon. It was as if they could read each other's minds and they could communicate without even using words. So after they leave the OR, longer length of stay compared to other specialties. So say ortho, hip replacements, patients are up and walking that very day. Whereas our patients, the average length of stay is about 7 to 10 days, give or take. And this really allows me an opportunity to further connect with the patient, as well as any family members that may be visiting. Not a whole lot right now because of our current situation. But then I also get to witness obvious improvements. So I see them working with physical therapy. I see them, breathing more comfortably. And then I love preventative medicine. So I always try to take a couple minutes to discuss healthy lifestyles and just really stress the importance of cardiac rehab after these surgeries. Okay. So what is cardiothoracic surgery? So this slide kind of shows you the main conditions that we or you could work in. So the top one being coronary artery disease, also heart failure, valvular disease, lung conditions, so lung cancer, COPD, emphysema, esophageal conditions, as well as congenital heart disorders. So there's a lot more to it than you might think right off the bat. And it's important to know that not all CTS jobs are the same. So starting with the setting, you can work strictly in the OR, or you can work solely on the floors, or you can do both. So I'll tell you how my job is, and then I'll kind of talk about some of the other options that maybe I interviewed for or that I also got to experience. So my job, I get to work in all of the settings, which is exactly what I was looking for. I wanted to be in the OR, I wanted to be on the floors, I wanted to work in the clinic. So I have that luxury. And so I'm trained on all of those things. And then, but like I said, you can kind of choose one or the other. And, depending on the job position, of course. Next, specialty. So as I mentioned on the slide previous, I'll go back to it real quick. There's all these different conditions that you can help treat. However, not every surgeon will do them. So for instance, my surgeons usually do the bread and butter of cardiac surgery, or the meat and potatoes, or I don't know, maybe if you're vegan, the carrot and hummus of CT surgery would be CABGs and lung resections or pulmonary resections, and like valve replacements, valve repairs. And so that's what I'll talk about today. But then there are other surgeons who strictly do heart failure or transplants, or maybe you only do thoracic, maybe you only do cardiac, maybe you do both. So there's a lot of variety. And, the cardiac cases tend to be longer. So maybe you really like the pathophysiology of the lung, but you're not crazy about the heart. You can certainly go into a strictly thoracic practice if they have a job opening. And so those tend to be shorter cases and, just kind of a different follow-up. So there are plenty of options out there. Or maybe at the end of the day, you hate the OR, but you love cardiothoracic. You can work in the ICU and care for those patients, or work on the floors and in the clinic and still be a part of that team. Okay. So moving to the next section, so that's hours. Again, this varies from hospital to hospital, really. Some people take calls, some people don't. I will eventually take call once I'm fully trained. And so all things to think about when you're considering any type of job, but especially a surgical specialty. Okay, so our first topic is going to be coronary artery disease. And I watched a couple of the other virtual shadowing experiences, and I noticed that a lot of people waited until the end to do their questions. However, I wanted to break it up a little bit. So first we're going to go over CAD, and if you have any questions throughout this segment, write them down, submit them to the team, and then I'll answer them at the end of this. Same thing with the pulmonary resection. We'll go do questions after that as well. And then at the end, we can talk about life in general. So let's move on. And we have coronary artery disease. So just always starting with epidemiology, you know, how does this affect us, the United States, the world? So cardiovascular disease is the leading cause of death, disability, and medical costs in the world. And then the main part of this slide shows you where coronary heart disease tops the charts. So it leads in incidence, which basically are like new cases or new patients, new diagnoses, and then prevalence, and that's new plus prior. So I underline those letters to kind of help you remember that moving forward. So incidence has an N, well, it has two N's, and those are the new cases. And then prevalence is all, so it's new plus existing. And then it also leads in poor quality of life and then medical costs. I believe I looked it up before this PowerPoint that coronary artery disease costs the United States $219 billion a year. That's, you know, treatments, medications, loss of productivity. It's a billion-dollar disease. It's crazy. So how can we fix these things? All right, so then this is heart disease death rates. So the chart's a little bit dated, but you get the gist. It hasn't really changed over the years. And anytime I see this chart, I just can't, the first thing that comes to mind is food. You know, why are the southern states have a much darker red than all the others? You know, maybe they're more sedentary, but I can't help but think, you know, the appetites in Louisiana are certainly different. If you've ever been to New Orleans, the food is great, but it's very heavy. And yeah, so anyway, so that leads me to the next topic being risk factors. So on the left, these are things we can't change. Like patients, you, me, we all get old. And then our sex, you know, men typically are at a higher risk than women until women hit the age after menopause. So menopause usually happens around like 51, 52. So once they hit the same age as men after menopause, then it becomes equal. And this is because estrogen is actually cardioprotective. And then we have family history. Again, something we can't really change. Things that we can control are listed on the right. This is smoking, you know, having controlled blood pressures, cholesterol, diabetes, that could be type 1 or type 2, leading a sedentary lifestyle, and then obesity. All right, now the pathophysiology of coronary artery disease. So it's the narrowing or complete obstruction of the coronary arteries. So the coronary arteries are the arteries that supply blood to the heart. This is ultimately caused by atherosclerosis, which is a buildup of cholesterol and fatty deposit. And so you'll notice that just like gross, thick plaque building up. And so when that happens, the way I like to think about the heart, like the heart is simply plumbing and electricity. So the blood can't get through. If the blood can't get through, then that part of the heart isn't being perfused and will ultimately lead to cardiac cell death, ischemia. So the symptoms for this are chest pain, shortness of breath, palpitations, fatigue with activity. These are the most common ones, chest pain being the most common. I'm sure you've all heard that like women will present differently, but I just kind of wanted to give you the top 4. All right, diagnosis and treatment. So patients are typically diagnosed if they come to the ER and they're having a myocardial infarction, and then that'll send them straight to the cath lab to get a cardiac catheterization. From there, we'll decide treatment options. Or patients may have symptoms, see their primary care doc or their cardiologist, and have a stress test performed. And if that's a positive stress test, then they buy themselves a cardiac cath. So this is an image of the cardiac catheterization. The arrow is pointing to the occlusion, which is probably 90% stenosed. And so you'll see the thick black. So that's the dye going through the artery. And then, you know, it starts to get A, very obviously narrow, and then B, also lighter. So those are kind of two indications. And this one's very obvious. Most of them are not this obvious. So it definitely takes some practice to learn to read these. And so you have a couple options when you have this patient. You can treat them medically. You can do PCI, which is percutaneous intervention, and then CABG, coronary artery bypass grafting. And we are going to talk about how we decide which is which, because we don't handle the medical therapy and we don't handle PCIs, that's interventional cardiology, but we are responsible for the CABG. So indications for CABG, there are quite a few. So left main, which is actually what we saw on the last slide. So that was the left main coronary artery, and that bifurcates into the left anterior descending, and that's actually what we saw. So left main with 2 or 3 vessel disease and a syntax score of greater than 32. That's usually the test question. You know, patient has left main with 2 to 3 vessel disease. What do you do next? And then also diabetes is a really tough condition, and basically anytime that you have diabetes, you are getting a fast pass to a more invasive treatment option. So diabetics with multi-vessel disease, it doesn't necessarily have to be left main. So that's something to kind of keep in mind in general. And then PCI, if that's not feasible or if the benefits don't outweigh the risks, if patients are unresponsive to optimal medical therapy, they may qualify for a CABG. Asymptomatic with silent ischemia, and this might be the patient who shows up for just routine screening with their cardiologist, and they have a stress test and it comes positive, they go to the cath is positive, they come to us. And then poor left ventricular function. The syntax score you can see on the left. There would be no reason to ever memorize this. There are calculators for everything. So if you have MedCalc, that's a great app to have when you're in PA school. I believe they have the syntax score. So, you know, we'll use this as well as the cardiologist to kind of help us determine PCI, which is less invasive, versus CABG. And the important thing is to remember that there is an art to medicine. So the 95-year-old patient who comes in and technically qualifies for CABG, maybe that's not the best option for them at where they are in their lives. So we have to think about quality of life and severity of the disease. So anything in medicine, nothing should be looked at as cookie cutter. Always think about the patient and what goes on. Look at them as a whole, and not just their cardiac cath results, but their life outside of this hospital. Okay, pre-op evaluation. So we get a consult from the cardiologist saying, hey, we think that this patient would benefit from bypass surgery. So we go and we talk to them, and some of the main points being, you know, what are some symptoms that you've been having, if you've been having any? Past medical history. So like I mentioned earlier, if they have diabetes, we're going to be concerned about risk of infection and poor wound healing. Family history, you know, did mom or dad have a heart attack at a young age? Surgical history, have you had any, have you had stents placed before? Or have you had any surgeries in the chest where we would have to be concerned about adhesions? Social history, do you smoke? That's obviously a problem. We want to talk about smoking cessation at some point. And then also drinking is a big one, because if they're heavy drinkers, and their liver's been affected significantly, then they might not produce clotting factors appropriately. So there's going to be a lot of bleeding in the OR, which leads me to bleeding issues. Are the patients on blood thinners? Do they have any sort of coagulopathy? And then something that you should also consider, like, do you have any urologic symptoms, any sort of active infections, like a UTI? And then we do the physical exam. So obviously we're going to listen to heart and lungs, and we're going to examine the vascular and as well as varicose veins, and I'll talk more about that. And then dental, especially if they're having valve replacements, and then skin, any sort of rashes or infections going on. Those are the big ones. Testing. So this is kind of your standard testing. Some surgeons may prefer a couple more tests that I didn't care to include, or maybe less, but we do carotid ultrasounds. So we look at the flow in the carotid arteries to basically, because our patients are at a higher risk for post-op stroke. So the more occluded that is, the higher the risk. Some surgeons will order a chest CT. This allows us to get a better look at the aorta. So if that's calcified, we may decide to cannulate different regions of the aorta, or maybe we'll want to do an axillary cannulation. So that would be over here. And then lower extremity ultrasound. So one of our conduits often comes from the lower extremities. And so we'll use an ultrasound to check out that vein, see if it's patent, see how big it is, because the conduits can certainly be too big or too small. Chest x-ray, baseline EKG, type and screen for blood, labs. Okay, now the fun stuff. Now we're in the OR. So the patient's prepped and they're positioned, and we're scrubbed, we're draped. So the first step being the surgeon performs the median sternotomy. So they expose, and then they use a saw to cut through the sternum, which will allow us visualization into the chest. And then usually during this time, the PAs are harvesting vein from the lower extremity. But before we get to that, the surgeon's up top taking down the lima. And then, so that's the left internal mammary artery. So they're dissecting that out, and we're down at the leg harvesting vein. So that's why I put the little star there, because that's us. And this is the, this is the surgery that I mentioned at the earlier of this talk, that we are solely responsible for. It's our own procedure in and of itself. And then after the venous harvest, we go on cardiopulmonary bypass. And so that's basically the blood is being redirected to the rest of the body for perfusion, however, giving us a bloodless field so that we can work. And then we graft the vessels to the heart and the aorta, and then we close everything up. So that's a quick overview, and we're going to go into those a little bit more in detail and try and show you a couple pictures. So first, endoscopic vein harvesting. 20 years ago, they used to do open vessel harvesting, which is what you see on the left. So patients would have these huge incisions from their groin all the way down their ankle, and recovery was horrible. Now we do endoscopic vessel harvesting. So you'll notice the patient here has about a 1-inch incision right at the knee. And then what you can't see, they'll have these like teeny tiny stab wounds at the groin and the ankle. So we take a long scope, we go down the leg. This is what it looks like from the outside. And then as we're going down and or up the leg, we are using a screen to look at the vein. So on the left, this is the fat dissection. So the vein is at the 12 o'clock position. So you'll see that kind of like that deep red color. And then the yellowish is adipose tissue. So we'll dissect under and over, left and right to give good exposure for when we get to the right side. So the right image is where we are taking down branches. So these are not my photos, by the way, but I think they're using a McKay system that has this little C-arm. So the C-arm allows you to manipulate the vein. So maybe you'll pull it to one side as a branch is coming off, so you can cauterize or, apply like heat to it and cut it off. So you'll take down all of the branches and then we'll remove the vein. After that, we'll prep it, tie off any branches that we cut off, and get ready to put it on the heart. So before we start any of that, we have to go on bypass, and that's bypass cannulation. So I tried to give you a picture of the different lines that are coming out of the heart. And this is, again, what helps us arrest the heart with the cardioplegia, and then the other cannulations go back to our bypass machine. All right, next step, we do distal anastomosis. And that is where we sew one end of the vein or the artery to the, where we bypass the blockage. So in the bottom right corner, the distal anastomosis, I guess you can probably see my mouse. So it's gonna be right here. So it's distal, so it's further away from the aorta. And then the proximal anastomosis will be any of the veins that we sew onto the aorta. So this is just a single bypass, but you can certainly have double or triple or quadruple. And again, sorry, my mouse is messing up. If this area were diseased, we would go beyond it and then put a graft here and take it all the way back up to the aorta. After that's done, we'll come off bypass. We'll put chest tubes in to help drain any fluid, pacing wires to help with arrhythmias, and then we'll do a sternal closure, and then we'll close up the muscle and the skin. All of this is done typically with the surgeon, except for the final closures. They're usually out of the room by then. All right, so this is on the left, we have just kind of a cartoon visualization of what you might see while we are sewing the grafts onto the heart. This machine is called a Hercules, and it helps hold the heart out of the way. So we can rotate it depending on where the blockage is, and it'll hold it out of the way, and you just kind of tighten it in place. And then you'll see the vessel graft here. This one's still attached. This is the lima that I was talking about earlier that the surgeon takes down. So it keeps its original blood flow. And then this cartoon doesn't have a vein graft, but I showed you that. And then the top right, that's just an image of chest tubes. So we usually put 3 in, 2 in the pleural space, 1 in the mediastinum. And that'll help drain any blood after surgery. Finally, we'll bring everything back together with sternal wires, which is the bottom photo. And on the left, we have sternal wires, and then on the right, sternal plates. This is, most people, when they think plates, they think orthopedics. So that's kind of another selling point that I try to talk about when people are with CT surgery. I was like, oh, we do everything. We have wires and plates and bypasses. So there's a lot of different techniques in CT surgery. All right. Now we have post-op care. So after we leave the OR, the patient goes to the ICU. This is where they're weaned off the ventilator and they're extubated. They're taking off any inotropes, any lines and catheters are removed. And this is where they'll start their beta blocker and their aspirin. Some hospitals have PAs who work in the ICU. During my cardiac rotation, they would have surgery, PAs in the ICU as well as in the OR. They also had PAs who were strictly in the CT ICU or the CS ICU. We have a different team where I am. So I don't typically care for the patients who are in the ICU as we are busy taking care of the patients in the step-down unit. And this is where we monitor their labs, daily x-rays, they're on telemetry. You know, we keep track of them to see if they can have their chest tubes removed or their pacing wires, because we'll need both of those out before discharge. We're responsible for advancing their diet, increasing their activity, working with PT, diuresing to their pre-op weights as patients are often fluid overload coming out of surgery. And then, of course, reviewing and updating their medications before they're discharged home or to a nursing home or a skilled nursing facility. Okay, so any questions about coronary artery disease, CABGs, the OR in terms of cardiac surgery there?
Yeah, so we had quite a few questions. Some of them are more general, so I'll hang on to them towards the end, and I'll go ahead and ask you the one specifically about the cardiothoracic stuff you just talked about, okay?
Okay.
So Megan was asking, does early menopause also increase the risk of coronary artery disease?
So I can't answer that for sure, but in theory, I would say yes, because if estrogen is cardioprotective, then and they're experiencing menopause sooner, then it would, yeah, in theory, increase your risk.
Perfect. And then Rochelle is asking, have you ever had a power outage during an endoscopy?
Gosh, no. So also something that I meant to mention at the beginning of this, I'm a new grad, so certainly keep that in mind. I'm going to try and answer your questions as best as I can, but I graduated in May and I've only been practicing for about a little over 3 months. We did have a power outage, but I was working the floors that day. I believe we have generators. I don't know, that's more of like a hospital question, but I hope that the OR wouldn't just go black.
All right.
Perfect, thank you.
And Prince Jazz was asking, why is dental health important for pre-op?
So if you think about, if they're having any sort of, well, we're specifically concerned about valves because it runs a risk of endocarditis. And so anything that's affecting your bloodstream can ultimately affect your heart. So if you have an infection in your mouth and that infection gets into your gums and that infection leads into your bloodstream, it's going to make its way back to its heart at some point, which I think that's a great question and something that we don't necessarily think about a lot of the times. And because people think, oh, like your CT surgery, listen to their heart and lungs and leave. But I certainly examine their mouth to see if they have good like oral hygiene or not, because gingivitis is ultimately inflammation of the gums, and inflammation, I could get into that for a long time, but certainly isn't going to help anything on our end.
Awesome, thank you. Let's see, Shaved is asking, do you do final closures?
Mm-hmm. So we'll assist the surgeon in putting in the sternal wires and the plating, and then they usually take off. So after that, we're responsible for closing up the muscle and the sub-Q and the skin, and then making sure that all of the dressings are placed appropriately and the chest tubes and the pacing wires. And this is so important. I remember on my rotation, I really like to take my time. I don't just slap a dressing on there. It's all wrinkled and it just looks unkempt. And someone told me that this is our PR. This is our public relations, because this is what the family sees. This is what the patient sees. So if they see that you just slapped a dressing on there and didn't care, who knows what you were doing when you were working on their heart. So remember that when someone asks you to put on a bandage, it's more than just a Band-Aid.
Yeah, that's a really good point. And kind of piggybacking off that question, somebody else is asking, how long does it take you for you to get familiar and comfortable doing these kind of procedures in the ER?
Great question. So it's going to depend on your hospital. So if your job is strictly in the OR and you're in the OR like all day long, that's all you do, you're certainly going to learn faster than someone like my position, where I'm learning the OR as well as the floors and how to manage patients medically as well. But in terms of vein, you know, you can start getting comfortable around, 6 months, where you're, ultimately doing things by yourself. But there's definitely a really drastic learning curve for CT surgery. Not necessarily the medicine, because, a lot of PA school is medicine, but you don't spend a whole lot of time learning about surgery. So vein harvesting is very tricky. And if you follow me on Instagram, I'll often post stories about like being frustrated or, and it's different every single day. There's a PA on my team who's been practicing for over 10 years. And sometimes you have really great vein and other times you have really crappy vein that just causes you a lot of problems and frustration. So while maybe other areas of medicine or surgery, it may only take 6 months to feel really comfortable with everything, I would say for CT surgery, if you're doing a lot of different procedures, then it's probably closer to a year or two until, after a year, you're like, okay, I can do this. I can at least get through this. And then it's probably not until like year 2 that you're actually really confident about it.
Okay, perfect. And is one more okay? And then we can continue.
Yeah, sure.
Okay, perfect. So Emma is asking, what is the difference between bypass and ECMO in CT surgery?
ECMO.
I'm sorry.
Okay. No, that's okay. That's fine. I had to just spell it out for myself. So there isn't a huge difference, but with ECMO, we're not necessarily performing a surgery to fix the heart, but rather to give the heart a break. So when we go on bypass, that is so we have a bloodless field to work on the heart. Whereas ECMO is to kind of bypass the heart to give it a break. Does that make sense?
Yeah, absolutely.
Okay.
And so the majority of the other questions were kind of general, so I'll just listen to your at the end.
Okay, perfect. All right. So the next section. So as I mentioned at the beginning, my job does cardio and thoracic. As I said earlier, you could get a job strictly in cardiac or strictly thoracic. So the other big procedures that we do are pulmonary resections. So this will be a little bit shorter, but definitely something that we do on a regular basis. So these procedures are, you'll hear the terms wedge resection, segmental, lobectomy, and pneumonectomy. So the top left is a wedge resection, and then the top right is a segmental. And the difference here really is wedge, you're like just taking the mass or the nodule and some of the margins around it. So it's the most minimal. And then segmental is technically, it's bigger than a wedge, but not as big as a lobe. And then the bottom left, we have a lobectomy. And as you know, the right, we have 3 lobes. So the right upper lobe is being taken from this image. And then on the left, we only have 2 lobes. And then finally, we actually had a patient with a pneumonectomy recently, which was pretty cool. And this is removing the entire either left or right side of the lung. So some indications for why we would do these procedures. The most common is malignancy. So primary lung disease is the leading cause of cancer for men and women combined. Whereas the leading cause for women specifically is breast, and men, I guess, is prostate. And so 2 types of lung cancer. So we have non-small cell lung cancer and we have small cell lung cancer. And within those, you can get into specifics of squamous or adenoma, but we're not going to get into that. And then ways that you'll stage these, because we've all heard of stage 1, stage 2. This is based on the TNM score, so tumor size, node involvement, and METs. And so resections are the primary treatment for stages 1 and 2. Once you get into stage 3, treatment tends to be a little more creative, and there's like subdivisions of stage 3. So again, just trying to touch on the high yield information. And then metastatic cancer or metastatic malignancies. The lungs are the third most common site for Mets to travel to. And so if we're going to do a resection, the requirements have to be that the primary tumor is controlled, the patient is medically stable for surgery, we're able to resect the lesions, and that there's really no other treatment option. So it's not ideal, but certainly something that can be done. Other indications that are benign, so blebs or bullae. Blebs are like air spaces in between the lung and the pleura, and then bullae are just bigger blebs, and they tend to be permanent. And so we want to remove these because they can cause spontaneous rupture or a spontaneous pneumothorax. So we will often resect those out. Masses or nodules, IR being interventional radiology. If they're unable to get the biopsy, maybe it's too central or midline, that's something that we can do. Bronchiectasis, infectious processes, assuming that medical therapy isn't sufficient. So empyemas, hemothorax, so empyema being like pus, hemothorax being blood, and bronchopleural fistulas. And fistulas are basically a communication between two areas. So in this case, it would be the bronchus and the pleura. And then we have COPD and trauma are our other benign conditions. So pre-op evaluation and preparation for these patients looks a little different. So we'll do risk assessment in terms of cardiac and pulmonary. We'll do PFTs, pulmonary function tests, we'll order those. And then we have predicted post-op values that we like to order, so DLCO. And this test assesses the lung's ability to transfuse the gases from the air that we take in into our bloodstream. And then FEV1 is forced expiratory volume in 1 second. So how much air can they expire in 1 second? And then chest x-rays, we get these daily, and then CT chest, depending on what exactly we are doing surgery for. And then before we take them to the OR, we'll put them on thromboprophylaxis, and anyone basically going to the OR will get this, as well as antibiotics, and that's the abbreviation for antibiotics. All right, so 2 techniques. On the right, this is an open thoracotomy, and oftentimes just called open. And then on the left, we have VATS, which is becoming more and more popular for the reasons that I'll discuss after this. So VATS being video-assisted thoracoscopic surgery. So you'll notice the biggest difference, just looking at this photo, is incision size. So with an open, you've got this very large incision, whereas with the VATS, you have 3 small 1-inch incisions. And then of course, patients will tend to have less pain with VATS and a shorter length of hospital stay. Also, it's important that sometimes you'll start as a VATS and you get in there and you realize that you don't have the best exposure, so then you might convert to an open thoracotomy while you're in the OR. Excuse me. After surgery, the patients typically go to the PACU, post-anesthesia, and then go to the floors typically the next day. We monitor their labs, we look at their daily chest x-rays. We also manage their chest tubes here as well. However, chest tubes in this case are less about fluid management and more about checking for air leaks in the lung. And then pain management, there is there are just a lot of nerves that run in this area. And so patients tend to be very uncomfortable. And then your regular advancing diet, getting them to ambulate and walk around with physical therapy, taking deep breaths, using their incentive spirometer, and going over any medications and getting them out of the hospital. Okay, so any questions about lung surgery or pulmonary resections?
Yeah, there were some really good questions. Let's see. Daisy Chang is asking, do you guys operate on pulmonary trauma that comes through the ER as well, like acute surgical intervention?
So my group doesn't. Well, I shouldn't say that. Trauma will typically take care of it first, depending on what it is. And then if it's an emergency and it comes to our hospital, then we would get called in to assist in that manner. So I would guess that trauma and CT would work together in that situation. I haven't personally experienced it. Usually, if it's trauma and the patient has, we can usually see them later once they're a little more stabilized. So I guess to answer your question, it really kind of depends. Sorry.
No, that's a great answer. So Mia would like to know, is there a higher probability of patients with lung cancer to develop other forms of cancer down the line?
I don't feel comfortable answering that just because it's outside of my scope. That's more of an oncology question. So I'm sorry, I can certainly get back to you if you want to shoot me a message on Instagram and I can get that answer for you though.
All right, perfect. And like before, majority of the questions were more general, so I'll just save those for the Q&A at the end then.
Okay, great. So before we get to the Q&A, I just wanted to give some cliche closing remarks and words of wisdom. Number one, be yourself all the time. So this applies to interviews for PA school. I legitimately cracked a very corny, very punny joke and really hit it off with the school that I ended up going to and just felt like I was at home. So be yourself with those, be yourself on rotations, be yourself in all interviews. Again, these are cliche, so don't hate me for the things that I'm saying. Unless yourself is just severely unprofessional, don't be that person. Number two, grades are not that important. While it certainly seems like it right now, do your best, but nobody wants a 4.0 person who isn't involved in anything or who doesn't care about anything besides their grades. And when you get to PA school, most people in PA school are used to getting, 90s and 100 on exams, but it's not going to be that way. And at the end of the day, just realize that care about what you're learning and not necessarily the percentage on the test and how it can make you a better clinician. If it was a question that was in the weeds and you're concerned about 2 points, be more concerned about whether or not you knew how to treat the patient or you knew how to diagnose them. Number three, always, always, always keep an open mind. Go into your rotations just with no expectations other than to learn and get exposure for these different areas of medicine. I don't think it would do you any good if you had one specialty in mind. I feel like for example, if you love orthopedic surgery and that's the only thing you're interested in, you're probably going to hate all of your rotations. And that's a lot of PA school. And that's such a unique experience, such a valuable experience. Like I said, I came from more of a primary care background, and I thought that's what I was going to do. And here I am working in CT surgery. By the end of it, I learned more about myself and what I wanted to do and took this route. So your experiences certainly don't define you, and don't let that keep you from pursuing something that might make you a little uncomfortable. Number four, as I mentioned in number two, get involved. Do something that is more than just about yourself. So there's plenty of opportunities when you're in PA school, whether it's locally, there's tons of stuff at the national level that you can do. And I was involved in AAPA, in a whole bunch of different roles. So if you have questions about that, if you're a PA student now, or even later, it's something that I really enjoyed and was the highlight of my PA school career. And 5, take care of yourself. So whether it's now or in PA school, remember that when you're on the plane, you have to put the oxygen mask on yourself before you help anybody else. So if you enjoy doing yoga or knitting or weightlifting or whatever, make sure that you incorporate that into your life, put it on your schedule, do it for yourself. There were certainly nights where I didn't want to go to the gym because I had things to study for. But then all I could think about was going to the gym and knowing how great that makes me feel. So taking an hour out of my day to go to the gym made my studying far more effective. Okay, Q&A.
Thank you so much. Those are really amazing tips.
Okay, let's see. Somebody asking, or somebody's saying, I'm definitely very interested in CT surgery and want to get involved more as a pre-PA student. Are there any programs or recommendations that you have that can help me get exposed to this field?
Shadowing. So this is definitely a great start. Maybe something else that is a little outside of the box. So I think shadowing is going to be your best bet. You could also look at jobs, with like CNA positions, or some sort of like ICU tech, and whether it's exposure in the ICU or exposure in the OR. And then the outside the box being even checking out like cardiac rehab. So our patients who have CABGs or valve surgery, we highly recommend cardiac rehab. And that's something where you could probably get a little exposure without, might just be a little bit easier to get into a shadowing in that setting. But if I think of anything else, I'll let you know. Again, just shoot me a message on Instagram, but I'll try and think of a couple more.
Awesome, thank you for that. And let's see, Kristen Schubert is asking, was your role affected by COVID changes?
Yes, so it's definitely been slow. Just our case volume is slower than usual. So that's where it was difficult to answer the question about training, because I've been working for 3 months, but COVID has definitely changed a lot of medicine. And however, I don't have much exposure to the COVID patients because all of our patients get COVID tested before they can come. And so I would say volume has definitely been the biggest one. And because if patients don't feel comfortable going to their primary care or their cardiologist, we're never going to ultimately see them. So yeah.
Perfect, thank you. Let's see. Lily was asking, how long was the training for your CT surgery job? Did you have to do any residency or anything like that?
You don't, and that's the beauty of being a PA. You can, there are certainly a handful of residencies available, and I didn't pursue a residency because that's not exactly where I want to see the PA profession go. I love that we have such on-the-job training, and I'm still being trained in everything. As I mentioned earlier, the medicine part comes easier because I know a lot of that from school, whereas they don't teach you how to vein harvest in school. And so that's been a huge learning curve. So I'm still very much learning.
Awesome. And let's see, Maddie's asking about your work-life balance as a CTPA. She said, would you be able to have a family and have weekends off with your PA job?
Yes. And again, I think that the biggest factor in this is like your job responsibility or the hospital that you work for. So my team is made up of 8 APPs, advanced practice, and I think 6 of them are married and 4 have children, I think, either young babies or teenagers. So it's definitely doable. But this question's hard to answer because it depends on what you consider balance. If you want to spend just as much time with your family as you do in your job, I personally don't think that that's possible. 50-50 in any career, you would have to work part-time, but it's certainly doable, as I have many friends in the profession who do so. So ultimately it's about what you want and how you can make that work. But I think the biggest factor is the hospital that you work at. Because with my team that's so large, once I am trained to take call, I'm only going to be taking call maybe every 6 weekends. So that's great. Whereas I definitely applied for jobs that were, you're going to take call every 3rd weekend, you're going to be on call every 3rd day. So it was crazy. So it's definitely doable and something to consider when you're looking at jobs and talking about the call schedule and those expectations.
Awesome. Thank you. So it seems like it really comes down to your specialty and which environment you're working in.
Absolutely. Yeah.
Awesome. So let's see. Shaved is asking, how much time do you spend in surgery versus in rounds?
So I'm spending more time in the OR than anyone else because I'm the one who's new and being trained. But my job is probably 50% OR, 40% inpatient, COVID. I'm not sure, but to give you an idea, I guess I can talk a little bit about my experience when I was in school, because when I did my cardiac rotation, COVID hadn't existed yet. So you could do 2 CABGs a day. So a CABG is typically 4 to 5 hours long. And again, this depends on your surgeon as well as your hospital and the turnover time in the room. But if you're doing, say, if you're only in thoracic, maybe you do 3 or 4 cases a day, as these are usually only an hour or 2. But a lot of variables. But right now, maybe we'll do a CABG and a lung. That's probably pretty average. So we have a long case and a shorter case.
Awesome. This is an interesting question from Jenna Yeager. She's asking, is it hard to be a woman in CT surgery? Are there any challenges you face more than your male provider peers?
That's a good question. And actually, according to NCCPA, I think there are more women in CT surgery as of last year. I think it's like 51% female. Kind of going back to the work-life balance, I think women may experience some resistance because, if they want to have a family and they want to be involved in their children's lives, but you definitely have to have tough skin. There are interesting personalities in cardiac surgery, but I can't say that I've experienced anything because I am not at a point in my life where I'm thinking about marriage or children. And not sure if that's something that I want. So I honestly can't think of anything. I think that we as women in the PA profession and CT surgery have done a really great job of showing our worth.
Fantastic. Awesome. Yeah, that's great to hear. Let's see. So Adriana wants to know, why do people retain water during surgery?
Fluid status. So there's a lot of like fluid shifts that go on, particularly in CT surgery, because they're losing a lot of volume in cardiac cases, which are high bleeding risk. Patients who are doing, maybe orthopedic. I compare orthopedics often just because they're drastically different. You're not gonna see a lot of like fluid retention with orthopedics because they're not working in at that same level in terms of volume loss and or gain.
Ready?
Okay, great, thank you. So someone was wondering if you could elaborate a little more on what you do when you're on the floor.
Yeah, okay. So days that I'm working on the floor, so we'll go through the patient list and we'll check out those in the ICU and see what happened overnight, any changes there. And then when we're on the floors, we're basically like monitoring their progress. So we're going over their labs and their imaging. So we're comparing their chest x-rays from the previous day to today, their breathing status, and when they have chest tubes. So we'll manage those. So we'll see if they have an air leak or if they're draining a lot. Patients can have pericarditis, so inflammation of the pericardium. And so we're, basically just looking at everything that, basically looking at the patient as a whole and trying to get them ready for discharge. So, trying to get them back to being able to go home and take care of themselves there. So, walking, breathing comfortably, making sure they haven't gone into atrial fibrillation or developed any arrhythmias. And then ultimately getting them ready for discharge.
Perfect, thank you, that was great. So somebody else would like to know, can any of these surgeries be done via robotics, such as the Da Vinci surgical system?
Yes, so you have the option to do robotic for both cardiac and thoracic surgery. I personally have not experienced any cardiac surgeries that were done robotically, but robotics is definitely becoming very popular with thoracic surgery. So I have had some experience there. Mostly when I was in school, not yet, because right now they're specifically training me for cardiac, and in time I'll be a little bit more involved in thoracic. But yes, it's definitely becoming very large at where I am.
Awesome. That whole aspect of like the advance of technology in medicine is really cool.
It is. Yeah.
So I like this question a lot. It says, what was the corny joke you made to get into your program?
This is my favorite joke, and I will be surprised if any of you even laugh at it. But one of the questions that I got in my interview was, what's something that just like makes you happy or whatever? And the first thing I thought, like, I love puns. I think they just make me belly laugh. It's embarrassing. And so my joke, they're like, oh, well, do you have a joke for us? And I was like, yeah, I have one. And they were kidding. Oh, you don't have to tell us. You don't have to tell us. I was like, well, I will. How did the tree get on the internet? And they all just looked at me like, I don't know. And I'm losing it. Like, I cannot stop laughing. I can feel blood like filling up my face. It logged on. It's a terrible joke, but it gets me every time. Something better that I came up with today. One of my team members just recently got a puppy, and so she took the week off to potty train it and do all that stuff. And she's coming back tomorrow. And I was like, I'm so sorry that your paternity leave had to come to an end. I'm done.
Apparently everybody loves it.
Oh, good.
Yes. Let's see. So Mira is asking, do you have any advice for boosting your science GPA?
I guess retake classes. I'm sorry, I'm not a good person to ask. Like I just erased all of CASPA from my memory. Because I know that's hard with the CASPA system because they calculate it weird. I'm really sorry. I'm not a good person. I guess take more science classes or take them again. I don't know. Sorry.
Okay, let's see. So somebody else is asking, what kind of patients are not candidates for resections or CABGs?
So kind of as I mentioned earlier, if patients who, for say like a CABG, the ones that I've seen most often are just advanced age. So, you know, a 92-year-old, do we really want to put them through this major surgery when we're not really sure of their life exists, like their, how many years they have left? So is it, you know, that's where the art of medicine kind of comes in. And then with resections, it also depends on where the nodule is located. But ultimately, they would come to us to have that removed. I'll have to get back to you. Again, I'm still learning a ton of stuff. So I can't think of anything off the top of my head that is screaming this patient isn't a good candidate for surgery, other than the option to do something less invasive like PCI. And resection, if they don't have good lung function, you know, theoretically speaking, if we're doing a pneumonectomy and we're removing the entire right lung and their left lung function is super poor, you know, that's certainly not going to put them in a good position. So in that situation, they wouldn't be a good candidate for a lung resection. And, you know, even sometimes if patients have really crappy lungs, we won't do heart surgery on them either, as these two systems work hand in hand. Sorry, I didn't have a more clear answer for you. But again, I'm still learning myself.
All right, thank you for that. Leanna wants to know, did you feel like scribing gave you good experience for PCE in preparation for PA school? I'm highly interested in emergency medicine. I
think, and I'm biased, but I think scribing is the best experience. Some PA schools don't like it or don't consider it as a part of your hours, but at least the company that I worked for, you were basically the provider's shadow. So, you know, you would follow them into the room and you would scribe the HPI, the physical exam. You learn so much. So I really think it's the best experience you can get. There were a lot of people in my program who had scribe experience. Not only does it get you familiar with the setting, but also, you know, medical terminology. And I would always have like Google pulled up on the side. So if something new came up, some sort of test or condition, I could like look it up quick. And so I think it gives you a nice like baseline exposure. And especially if you're interested in emergency medicine, there are scribes everywhere. So I'm a big fan.
Awesome. So Alejandra is asking, why are thoracotomies not performed more as life-saving measures? Not sure if I'm saying that correctly.
Yeah, thoracotomy is correct. I don't really understand the question.
So I guess she's just asking why it's not a more commonly performed procedure.
Well, it is, as we do them regularly, but they're not typically life-saving. We don't do a whole lot of like emergent thoracotomies. I would have to know more about a situation to answer that. Sorry, I'm just a little confused by that question.
Okay. All right. Sorry about that. I'm not sure myself, but let's just move on to the next one.
Again, you can always reach out to me on Instagram. I'd love to chat.
Perfect. So Prince Jazz is asking, as a CTPA, is there any growth in this specialty?
guess that depends on what your definition of growth is. So there are opportunities to, if you're working with one practice who maybe does kind of the basics with CABG, valvular conditions, then you could, based on that experience, maybe you want to get more involved in heart failure patients where you're doing LVAD procedures or transplants. I personally am very interested in leadership roles and research. So that's kind of where I'm taking things. And now that I think about it, I think that would be my answer for almost all specialties. If you're primary care, where do you go from here? And, maybe you make a lateral move, but you're not moving up when you change specialties. So I'm looking at that from like a leadership or an administrative standpoint. So for instance, my boss is in charge of all of the CT surgery PAs. And so maybe later down the road, that's something that I want to be involved in and kind of help with more of the administration side of things.
That's awesome. Thank you. So we're getting a lot of really great questions, but we want to be respectful of your time. Are you okay with answering maybe like 2 or 3 more questions?
Yeah, that's fine.
Awesome. Okay, so the next one is, during your involvement with AAPA, what are the main items you advocated for in the past?
Yeah, so there is there's an event every year called LAS, Leadership and Advocacy Summit. It's in Washington, D.C. So some of the policy and the legislature that we've advocated for on Capitol Hill in the past couple of years is diabetic shoes. Fun fact, PAs can not write a prescription for diabetic shoes. If you don't know what I'm talking about, they're typically like a really ugly tan or black color, and they're like big bulky shoes. But they're great. They're great for preventing infections and ultimately amputations. And what's frustrating is that, a lot of what goes into politics is money. And so we go on the Hill, and we've been advocating for this particular issue for a few years now. And, explaining to these politicians that I'm a PA and I can participate in an amputation of someone's extremity, but I can't write them like a prescription for diabetic shoes. Basically saying that they would have to go to their physician to get this prescription. But maybe I'm the PA that's been working with them for 10 years and they know me and we have a great relationship together. So that's one. Yes, last year we passed, previously, PAs needed a co-signer for ordering home health care, and that was just completely unnecessary in the same aspect that it breaks up continuity of care. So, if I'm the PA who's been working with you and then I am trying to get home health care to come out and take care of you, now you have to go see the physician so he or she can order it. It's very unnecessary. And a lot of the legislature that we advocate for is just very archaic, where other professions have, we're a newer profession. So we've only been around for 50 couple years. And it's just kind of the language that's being used that keeps us from participating. And then I've been involved in the House of Delegates, AAPA's House of Delegates, for the past 3 years. And you can look that up and kind of see the changes that we've done and the resolutions that we voted on. I did write a resolution to be presented at tomorrow's meeting, actually. However, with everything going on, I and my team who helped write it decided not to submit the resolution. So I don't want to tell you what that is. But for lack of a better term, it's pretty awesome.
Awesome. Thank you
That's
so
so
much.
awesome.
That's really incredible work. Like we definitely appreciate you doing that. And even though some of those things might seem insignificant, maybe not like the most major things like the diabetic shoe thing, without people like you, the profession wouldn't be anywhere near what it is today. So sincerely appreciate you taking the time out of your already busy day to do things like that. You're paving the way for, you know, future PAs and the future of medicine in general.
Oh, thanks.
Yeah, absolutely. So kind of a general question. Amy wants to know, what is your favorite part about the job?
Everything. I love going to work. I really do. Like I said, I'm still very new to things. I learn new things every day. And so I love that I can be in the OR and learn all these skills, but then also care for patients who just had this major surgery. And again, like help see them progress while they're in the hospital. So I don't know that I have, if I had to choose like right now, it's taking vein, because I just get so excited. I get excited about like little victories that I have as I'm learning. And even though like some days I want to pull my eyelashes out one by one because I'm frustrated and it's difficult. Like I keep coming back for more. I want more experience. I want more training. I just want to get better. So that's my favorite right now.
Yeah, that sounds awesome.
Yeah, that's super cool.
So let's see. David is asking, if you weren't in CT, what other specialties would you consider? And was it difficult to find a job in CT after you finished your PA program?
Okay, so I might answer that in reverse order. So for me, I personally did not have a huge struggle finding jobs. I think a lot of that is because I was open to relocating, whereas if you only want to stay in one area, there may only be so many cardiac surgeons. So I was, as I mentioned, I was from Pennsylvania. I went to PA school in New Jersey, but I interviewed at like places in Portland, Oregon, Raleigh, North Carolina, Arizona, Atlanta, Georgia, Cleveland. So I was willing to go nearly anywhere for the right job. So I think that really helped me. And CT surgery is a little more difficult to get into as a new grad because the lifestyle and the lengthy surgeries aren't for everyone. So I think what they want to know that you know what you're getting yourself into. So they want to see that you did a rotation in it. Whereas other areas might not care as much. It's not impossible to get a job in CT surgery without doing a rotation or having the exposure, but it's certainly more difficult if you don't. And then I got that question a lot actually when I was interviewing, and it was, if you don't get a job in cardiac surgery, what will you do? And this is what I wanted to do. Like when the time came, this is what I want to do. I remember exactly like the case, like being like helping take vein and then going up to the chest and helping to first assist and thinking like, this is where I belong. Because sometimes you're in the OR as a student and you're not doing a lot and the only thing you can think about are how bad your feet hurt. But that experience, I was like, this is it. Like I'm willing to go through all the compression socks in the world if this is what I get to do for my job. So when I was asked that question, I, often responded with, if I don't get into cardiac surgery within, like trying to find a job after 3 or 6 months post-graduation, then I will look for jobs in surgical specialties to help with surgical experience so that I can ultimately get a job in cardiac. So my answer to that was I really like vascular, which I figured, if I don't get into cardiac, I'll do vascular, I'll get great experience, and then one day go back to cardiac. But if we're not talking about jobs, like real life, what would you do or what's your plan B? I love diabetes. I'm just fascinated by it. I talked about this on my story the other day. I think it would be really great if I was just a diabetes expert. And so that's where I like to talk. A lot of our patients have diabetes. So, you know, that's when being on the floors and having more time with them, I can, you know, kind of educate them about chronic conditions that, to help make their surgery successful, because we don't want to do another bypass on them. That is not the goal. We want to have one CABG and you should be well on your way. Like, we don't want to see you again, because when you do redo anything, like redo sternotomies, with all the adhesions, it makes it all the more difficult. So we want our surgeries to work.
That's amazing. Congratulations to you. I know you're relatively new in this position, like you said, but that's so cool. Very inspiring to hear that you got into to be able to do something that you love like that. But so I think this is a really good final question to wrap it up on. They're just asking, what is your opinion on the future of PA? So if you could discuss things like the role, whether you see likelihood of oversaturation, just anything along those lines.
Sure. I think we have made tremendous strides in the short time that we've been a profession. If you look at the history, like where we started and where we are now, I think it's incredible. And I don't see that slowing down any. But at the same time, it also takes a lot of work. It takes a lot of work. We need people to advocate for the profession, whether that's at the state or national level. So I do get frustrated when I overhear other PAs complaining about their job or their scope of practice, but aren't willing to do anything or get involved to see those changes happen. And, you know, one of the things that I'd like to see more of is I'd like to see more PAs on like medical boards at hospitals. And so I want to see them at the table, because, you know, there are obviously a lot of physicians, but there are a ton of nurses, and we should be there too. We're just as important. And everybody has something valuable that they bring. So I would like to see more PAs at the table making these decisions as well. In terms of oversaturation, I did recently see that there were quite a few programs popping up, and I'm not a big numbers person, so I don't know that I can give an educated answer as to whether or not I think that's going to happen. I think there's a lot of need for providers everywhere, especially in like rural America. So I don't want to dampen the enthusiasm of that at all. So maybe that's a question for like an economics person.
All right, thank you so much. I think that's a great stopping point for us. We really appreciate you taking the time to do this. The whole way through, it was amazing. You had a lot of really cool pictures. You're a great teacher.
Sure.
Like, I never had any idea what a bypass was. Like, I would always hear that term thrown around, but just, you know, you showing it with your mouse clicker and just kind of pointing to the things. I was like, is that all? Like, that's where the vein comes from? It makes so much sense. I thought it was something so much more complicated.
Guys, it's so, yeah, we take vein from the leg, or like I said, you know, maybe we'll take the radial artery as one of the conduits. It's really cool. And like I said, if you have any questions and anything that I couldn't answer to your standards, I'm more than happy to look into it. Like I said, I'm still very new to this position, but I think I bring a nice perspective on things as a new grad starting out, and that there's a lot to learn. And imposter syndrome is very real. I feel like this phrase has come up a lot more in the past couple of years, where, you know, you kind of question your worth, whether that's in PA school, do I deserve to be here, or on your job. But I think the PA profession in general does a really great job of, you know, on the job training, and, you know, and that's what I like about our profession, as opposed to requiring a residency or a fellowship. And that way we can make those lateral movements later on in life if we want.
Yeah.
It's incredible.
And it seems like I feel like nobody would ever guess that you were just starting out. It seems like after all your advocacy and all this kind of thing, you're so attached to the profession, you can tell that you really care about it. So that kind of shines through, and you really do seem, very passionate about it. So we appreciate you.
Well, yes, I love this. I love that you guys are doing this. And like I said, I hope that I can continue to help with shadowing sessions the best that I can. And I would love to teach one day. I think that would be really cool.
Yeah, you seem like you would be amazing at it. But yeah, that was one of our biggest sessions ever. We had nearly 200 viewers all the way throughout. So your message was heard extremely well.
Oh, fun.
And I know you might go back through and look at the chat, but just to kind of give you an idea of what everybody was saying, like there were a million thank yous. Everybody loved your attitude, just like so many compliments the whole time. Everybody really liked your joke. But yeah, really, you have an amazing personality. You're so easy to talk to. I'm sure your patients reciprocate that same feeling. So you're awesome.
Oh, that means a lot. Yeah, thank you so much. Sincerely, absolutely. But I guess that's a great point to stop. Thank you so much for doing this. We'd love to have you back anytime. For sure. Yes. All right. Thanks so much. Bye. Take care. Have a good night. Okay, guys, that was a really good session. Thank you so much for joining. As always, we really appreciate it. Yeah, absolutely. We're about to drop the quiz right now in the chat. It'll also be on our Instagram link tree. If you have any questions about that, let us know anytime. We have a lot of presentations coming up. I think our next one is on the 25th as of right now, but we might have something sooner. So that'll be Thanksgiving week. We're talking to a lot more PAs, a lot of really cool, interesting professions. We're going to be putting out a few more polls to see kind of what you guys want to see. Or we have some PAs that are asking, well, do they want to see this or do they want to see this? So we feel like it's probably good if we ask you directly rather than just making that decision on your behalf. So keep an eye out for those. They'll be on our Instagram. If you want to vote, please feel free. We'd love to hear your feedback. But yeah, so quiz is up. Do you want to talk to them about that?
Yeah, so I just sent the link out in the chat for the quiz. It'll close at 8:35 p.m. Central, so you do have an hour. And again, as long as you get at least 4 out of 5 correct, you will get the certificate. We'll email that to you within about a week. I think that's it for the quiz.
All right, perfect, guys. I think that's pretty much everything. We really, really appreciate it. Thank you so much. Y'all are awesome. We'll be right here hanging out in the chat if you want to say anything, or if you have any questions for us, just let us know if there's any technical details you don't understand or anything really. So we'll be right here in the chat, but we're gonna go ahead and go now.
Oh yeah, and we'll also send out the link for her Instagram if you'd like to follow her on Instagram. She has a lot of really, really great posts, super informative, very educational. Often on her stories she'll have quizzes, so you can learn a lot from her as well. If you're interested in this specialty. She also posts a lot of tips for LinkedIn, how to get a job, stuff like that. So definitely check out her Instagram.
Yes, highly recommend. But okay, guys, thank you so much. We really appreciate y'all. We'll be right here if you want to say something. Take care, y'all. Good night.